All right, so this is recording number 4, I believe, and we're summarizing the pharmacokinetics, and then we're going to talk about pharmacodynamic changes in the elderly in this video. So if we think about absorption, distribution, and clearance, which is broken down here into metabolism and renal elimination changes, the upshot for changes in bioavailability are that drugs may be slowed, the time of onset may be increased, but usually most drugs are fully absorbed, so the absorption itself is not affected. Now, there could be exceptions to this, things that need active transport to be absorbed, like iron, or things that are high extraction drugs. They could have an increase in bioavailability because of decreased P450 activity for drugs that have high extraction given orally. Distribution. So changes in distribution are usually due to changes from being higher amounts of water, a percentage of the body being water, to higher percentages being fat as we age. So decrease in volume distribution of hydrophilic and an increase in volume and distribution of lipophilic drugs, and also the changes in binding. So albumin is decreased as we age. You can have increases in AAG, release is more common in the elderly population because of disease states that they encounter more commonly. As far as clearance, changes in hepatic clearance, the P450 system declines. So it's phase 1 metabolism are affected primarily, not phase 2 drugs. So phase 1 drugs that are metabolized by the P450 system, we lose 1% per year as we age. And also, so for high extraction drugs, clearance is going to be decreased because it's dependent upon liver blood flow, and liver blood flow decreases as we age. So, for example, I guess we talked about, I don't think we prefer these lorazepam, oxazepam, and temazepam for benzodiazepines because these are metabolized by phase 2 enzyme systems, which are unaffected by age, and there's no active metabolites. Whereas other drugs like diazepam are cleared by the phase 1 enzymes and do have active metabolites. Therefore, we see this increase in half-life with age due to a decrease in clearance and probably an increase in volume because it's also fat soluble. All right, going back here. Okay. So it is important for several drugs, some of them listed here. Also, renal elimination is affected because we have decreases in glomerular filtration rate and renal plasma flow in general. You really need to pay attention to renally cleared drugs with age, as we age, especially those with smaller therapeutic indexes. This is a general rule of thumb. I don't know if I've ever used this clinically, but in general, you can say a typical patient is 60 years old. So here you would assume that it's age of a typical, and then you put your patient's age in here, and you can use that to make a ratio to get a general idea of how to change dose rate for patients that are as they age. We'll just do an example of that, but usually you can find more data to be more specific than that, but that's a general rule of thumb. All right, moving on from pharmacokinetic changes to pharmacodynamic changes as we age. So this is about the actual changes in receptors, right? And what's actually in the body, not about how the drug gets to those receptors, right? So with increasing age, there's an increase in intolerance to drugs as a result of the pharmacologic targets or the receptors. End organ sensitivity can lead to exaggerated or diminished pharmacological responses. So for example, beta blockers and beta adrenergic stimulants, because there's fewer beta receptors, beta blockers can have a pronounced effect. And beta adrenergics may be harder to increase beta activity with beta adrenergic stimulants. There's just fewer beta receptors available. There's a higher risk of digoxin toxicity because of this. Luckily, digoxin isn't used that much anymore except for AFib. But again, there's a higher risk because of this loss of these exaggerated responses. There's also a depletion of neurotransmitters like acetylcholine, dopamine, and serotonin. So you can again have an exaggerated response to the blocking effects because there's less of it to begin with. So what do we see in the cardiovascular system? We'll see a decrease in the effect of beta agonists, and you can see either a diminished or enhanced response to beta blockers. Usually I've seen an enhanced effect of beta blockers because you have fewer available. But if you're on them for a while, you can actually induce the beta receptors to increase, but it's harder in older, it doesn't happen as quickly in older patients. You have an increase in orthostatic hypotension, so you want to make sure that the patients are careful when they get up with particular drugs that will drop their blood pressure, and they're at a higher chance of digoxin toxicity because of age. Again, CNS changes that occur, we have a less effective blood-brain barrier. So it's easier for the drugs to get into the blood, into the CNS than in younger patients. This results in an increase in confusion. And antiepileptics, you can sometimes decrease the concentration that's needed to be effective in decreasing seizure activity. There are also electrolyte changes, and there's a less ability to adjust to sudden changes as we age. This is why we see a lot more hyponatremia that becomes life-threatening, and hyperkalemia. So you have to be, where this might not be so worrisome in a younger patient, it can be life-threatening in an older patient. So increased sensitivity to CNS depressants, you want to make sure you're very aware of CNS depressants because you can have a much greater effect at the same concentration. So an exaggerated response, pharmacodynamic response. Same thing with anticoagulants. So you have to start at a lower concentration than you would, at a lower dosing regimen than you would in younger patients. All right, so this is some more data that shows that the minimum alveolar, I hope I don't have to say that again, concentration, or MAC, is the concentration that is needed in the lungs to prevent movement or motor response. So these are drugs that we give in anesthesia. And then what am I doing here? Okay, so how much is needed to prevent movement in 50% of subjects? So this is the minimum, this is the concentration that you have to have relative to somebody at 40 years of age. So one would be the same. So you can see at 40 years of age, this is how much that was needed. If you're younger than 40 years of age, you need a much bigger dose, don't you? And as you age from 40 years on, you can see that the dose that you need to get this same prevention of movement decreases. So you need lower doses as you get older. It's one example. All right, so now we're going to go into drug-drug interactions and drug-disease interactions that you need to be more concerned about in the elderly. So drug one being ACE inhibitors, drug two, nonsteroidals. When they are given together, you have a higher risk of hyperkalemia. And we also may see a higher additive decline in renal function due to giving both these drugs together because decreases in renal plasma flow with both. So adding these together could put your patient at higher risk for hyperkalemia, which is really scary in the elderly, as well as an additive effect of decline in renal function. Giving ciprofloxacin with olazapine. Remember, cipro is a inhibitor of CYP1A2, which could increases the olanzapine concentrations. Again, will be exaggerated in the elderly. Digoxin and furosemide, often given together, can cause hypokalemia, which will increase risk for even a higher risk for dig toxicity. So dig toxicity, furosemide will decrease your potassium as a diuretic and therefore put you at higher risk for dig toxicity. It doesn't mean you can't give these together, but you have to be careful and know that it might there be an exaggerated response in the elderly, and they can't respond as easily as young patients. Nitroglycerin and sildenafil, which I think everyone knows about, increase of severe hypotension. Spironolactone and potassium chloride. Remember, spironolactone is a potassium sparing diuretic. Therefore, giving it with potassium, you've got a risk of hyperkalemia. Again, you have that risk in every patient, but it's going to be enhanced in older patients. Verapamil and atenolol, they're both AV node inhibitors. So you can slow bradycardia, cause bradycardia and hypotension. Again, exaggerated in the elderly. Warfarin and acetylsalicylic acid are going to have an increase in risk of bleeding. Remember, anti-platelet drugs and anticoagulants have an exaggerated response in the elderly. Drug disease interactions. Anticholinergic drugs in patients with dementia equals delirium. Avoid anticholinergic drugs that have anticholinergic side effects if you can in the elderly, because you may enhance their delirium. Antipsychotics in Parkinson's. If you give antipsychotics with patients with Parkinson's disease, you may see a worsening of their symptoms. Aspirin with peptic ulcer disease, you can see GI bleeding. First generation calcium channel blockers with congestive heart failure. Again, you can see a worsening of the heart failure. Non-steroidals with renal failure. You're going to have an enhanced renal failure, again, decreasing perfusion of the kidneys. Non-steroidals in heart failure, you can see worsening heart failure. We use a lot of non-steroidals in this group, so you have to doesn't mean you can't do it, you just have to be careful. Thiazides and gout. Thiazides will worsen gout. Tricyclic antidepressants with epilepsy. You can see tricyclic antidepressants can lower the seizure threshold, and and even more enhanced in the elderly. And I think that's it. Yeah. Then we're going to just review some class pearls and references in the next video, and then we're going to do some cases and we'll be done. Thanks.